Hi, everyone. Thank you so much for joining us today. We are going to be talking about teaching and assessing critical thinking skills. My name is Dr. Shirley Schipper. I'm a family physician and I'm based at the University of Alberta, Department of Family Medicine. I'm a family physician and I teach in a teaching clinic and have been doing that for a long time. I was also program director for the Department of Family Medicine at the University of Alberta. I wanted to mention Dr. David Ross, who is a colleague of mine who was our assistant program director at the time, and he and I did a lot of work on teaching and assessing critical thinking skills, so wanted to make sure that I acknowledged his help in this presentation. So by the end of this video, I'm hoping what you will be able to do is understand some basics of critical thinking in medicine, and I'd like to go over a little bit of research that we've done locally. I'd like you to be familiar with a few different critical thinking tools to use in teaching. And then hopefully by the end of this, I'd like you to be able to use one of them or think about using one of them in your practice, or even just sharing one of these tools with one of your colleagues who might be able to use it as they teach medical students or residents. Why is critical thinking important? The basic reason is to try to decrease diagnostic error. We know that about 10 to 15% of all encounters have some sort of diagnostic error, and for that impacts patient safety. Medicine requires us to be excellent in making diagnosis and prescribing therapeutics to our patients, but some learners really still need help with this while they're developing their diagnostic skills. So I want to go into a little bit of research. I was a part of an educators group that did research based at the University of Alberta, Department of Family Medicine. Initially, we just did a systematic review on critical thinking to see whether or not critical thinking was reliably correlated with academic success in medicine and other health professionals. After a lot of research on this, we found that there was actually a test called the California Critical Thinking Skills Test, and it was better at predicting success than many other types of testing of critical thinking. This test is used really frequently in the United States and other parts of the world in nursing, military, business schools, and for selection into medical school programs. So after this large systematic review, we actually published a paper called Do Scores on 3 Commonly Used Measures of Critical Thinking Correlate with Academic Success of Health Profession Trainees? So you can obviously gather that the answer was yes, and we were able to publish this in Academic Medicine in 2013. So from this, we decided to do a project and took the 2012 Family Medicine Residency Program cohort and invited them to participate in this study. So we included urban and rural program residents and did 3 separate tests, one at entry, one at year 1, and one at the end of training. And we followed them through their residency training program and collected data from CARMs when they applied to the program in the first place, and then looked at how they did on the certification exam at the end of training. So after this cohort went through residency training, we actually found that the CCTST that I described earlier was reliably correlated with performance on all sections of the MCAT. The MCAT is the test that students do in order to enter medical school. So it showed a correlation between this test and that screening test. There was, however, no correlation between any of the CARMS scores. So we know that residency programs across Canada look at file review and they do interviews and they choose a number of things during CARMS, which is the Canadian Residency Matching Service, and it's how we select students into residency. And there was no correlation at all between this test, and there was no correlation between CARMS scores and how the residents did in academic performance through the training program. What we did show, though, was performance on the CCTST was reliably correlated with performance on both parts of the certification exam at the end of residency training program, so both the written and the oral portion of the exam. So then we published examining critical thinking skills in family medicine residents. This was a paper that we published in 2016, and it looked at how the CCTST correlates with performance. So that research is super helpful, but what do you do about residents that are already in the program? So an assumption that we make is that novice clinicians naturally advance in their clinical reasoning with enough exposure to clinical scenarios. But we know that this isn't always true. About 10 to 15% of residents will experience difficulty during their residency training program. Sometimes it's a personal setback, sometimes it's a mental health issue, and other times it's just that they aren't developing a skill. So without focusing on critical thinking and problem solving, progress is sometimes uncertain. And for these residents in particular, it's very difficult for teachers to know how to help and how to assess this sort of skill. So if we break down critical thinking a little bit, what it really is purposeful, reflective judgment. Clinicians and other health professions follow a pathway when they're talking to their patients and trying to figure out what's wrong with them. Critical thinking is how we think about our thinking and how we stop and reflect on what we're hearing. Jerome Groopman wrote a book called How Doctors Think, and this is actually one of several books out there that examine how clinicians come to a diagnostic answer when talking to their patients. And what this book showed, and many others like it, is that we can actually assist in teaching residents and students to do critical thinking, and that this can have a profound impact on patient healthcare. So generally, there's two pathways of thought. There's intuitive and there's analytic. Intuitive is rapid, single-channel thought. So when a patient is telling you their history or presenting you their history of present illness, you can follow them right along. And you're thinking, yep, I know what you're thinking. I know where you're going with this. And so then you naturally and quickly come to a diagnosis, a treatment, and a plan. But then there's also analytic thinking. Analytic is multi-channel, it's slow, and it's deliberate. And that happens often with us when we're talking to a patient, maybe too early in the diagnostic journey, where we don't actually know yet what's happening. They're giving us pieces of information that don't quite fit. And we naturally slow our thinking down to think about, could this be something or could this be something else? You still might come up to a diagnosis or a plan, but it might not be as quick as with intuitive thinking. It's important to remember that bias plays into this. This is tool number one that I often share with other teachers, is that there's slow thinking and there's quick thinking, and you need to think about and verbalize what bias is. An important part of this diagram is the arrows that go between intuitive and analytic. So naturally, clinicians will either speed up or slow down their thinking. Even if you're hearing a complex patient presentation, sometimes you'll think, oh, okay, well, actually, this is starting to follow a path that I recognize, and you'll go back into intuitive thought. Or a patient will throw something out there that doesn't quite match, so you'll slow your thinking down and become a little bit more analytic about what they're talking about, maybe ask a few more questions about that symptom that they're presenting. So going back to the bias arrow that you saw there are hundreds of different types of bias. If you want to look into this a bit more, Crosscarry has written a number of different articles about different types of bias, especially in the medical arena. There's 4 common types of bias that I like to think about when I'm teaching: anchoring, availability, attribution, and overconfidence. Anchoring type of bias can present in situations where a patient is presenting a number of symptoms, and a resident or learner has already made a diagnosis in their mind early on, and they're convinced that's what it is. These are residents and learners that we'll often call early closers. And so despite additional information coming into the picture, they've really anchored themselves down to what they think is happening. Availability is the type of bias where it's just the most common thing. So when you hear hooves, you think that it is horses for sure, not thinking about zebras. Attribution bias is based on judgment and stereotyping. So a patient can present with liver disease or pancreatitis, and a resident or a learner will automatically assume that they use alcohol. The fourth is overconfidence, and we've all seen medical students and residents who are overconfident, and they just are very, very sure that their diagnostic skills are right on the money. So midway through this video, I just wanted to do a couple of take-home points or teaching points. The first one is, if you notice bias, identify it and then talk about it. It's very helpful for residents and students to understand what bias is, and they've often never been aware of this as a part of how they do thinking and how they think about patients. The second teaching point is, when your pathway shifts from intuitive to analytic or vice versa, tell the learner. Tell them, okay, so hold on. I've just heard you say something. Let's slow down. I want to hear a little bit more about what's happening with this patient, and let them understand that you've had to slow down because of something specific. The second tool I like to use is a basic arrow, and I'll often draw this with residents or students when I'm trying to determine how well they are doing critical thinking. So if we take the first arrow where there's diagnosis in the middle, If a student or resident is trying to present to me a patient and they think that it's pneumonia, I'll draw out a line or an arrow and I'll say, okay, how certain are you that it is pneumonia? So they'll think about that for a little while and they'll say, well, maybe 70%. So I'll actually mark on the arrow 70% and the diagnosis of pneumonia. And then I'll see myself where I am. Am I at the same place? Am I also 70%? Or is there something that they've told me that makes me more 30%? And I'll discuss if there is a difference and figure out why there's a difference between 70 and where I'm thinking. Then I'll also say, okay, well, what would bring you from 70 to 100? And they'll think about different tests or different things in their history that would bring them closer to 100. Sometimes residents or students will realize, actually, I didn't ask that. I have to go back in the room and figure out if they actually do have sputum or if they've had a fever. So they realize the parts of the symptoms that they haven't yet thought about and how that would change their diagnostic certainty or not. You can do the same thing with treatments to say, with treatments or with interventions, how much do you feel that you'd like to do this treatment or say this radiograph based on what the patient is telling me? At what point would you think that you don't want to proceed with this? So what would it take for you to say, you know what, I don't actually want to do this. I want to see how long it takes for the patient to get either better or worse. Or what would push you into, for sure they do need a CT. So this arrow tool is probably one of the most common tools that I use. And what I like about it is all you need is a piece of paper. You don't even really need one if you don't have one. You can just say between 0 and 100, how certain are you or how uncertain are you about a diagnosis? If you're trying to work with a resident or student and you're really trying to break down where they're having difficulty with critical thinking or problem solving, you can do case segments. And so case segments are you just break down a patient's scenario or patient's case into very specific parts. So this diagram or this chart that you're looking at now is an example of this, but you can do it in any way that you want to. I don't use a chart to teach this anymore because I'm familiar with it, but I'll give you an example of how I use it. So a patient could be coming in who is 45 years old and is presenting with chest pain. So that is all the information that you've got, and I'll do a critical thinking exercise with the resident. So I'll say, just based on a 45-year-old with chest pain, what do you know? What do you think so far? What do you think the possibilities are? What would be the first and the second diagnosis if you had 100 people who were 45-year-old males and were presenting with chest pain? What do you think most of them would have? What information do you need in order to make a decision? And then you'd add another piece of supporting information. So it can be their past medical history, their history of present illness, or you can introduce something like they have a cough. So now what does that do? How does it change it? Does it make it more obvious that there's something going on or less? What action or next step would you do and why? And then the third step is you can add as much supporting information as you want, maybe something that actually changes the diagnosis in your mind. You can also do scenario-based questions at this point. So say it wasn't a 45-year-old male. What if it was a female? Would that change your mind? What if this female was on birth control or a smoker? Would that make a diagnosis more common or less common? So you can go down different parts of a case report and do questioning types of questions as you present each piece of information to see where the critical thinking changes and where it doesn't. And these little bits of information can be super helpful to identify where there are learning gaps and where you need to then focus your energies as a teacher. This is the last slide on this video, but it's super important. I really like to think about this when I'm trying to decide how to assess a learner that's in my practice. So there's a difference between those that are really high critical thinkers and those that have low skill in critical thinking. And there's some points here that are important to think about. Those students who are really high critical thinkers are able to identify problems really early in the case. They ask for additional information that helps clarify the problem or solution, and they can correctly rule out problems when refuting evidence is presented. Those learners who are low critical thinkers identify problems really late. So when a patient has gone through all of their history and physical, then maybe they would come up with what the problems are. They sometimes ask for information that's irrelevant. And this, you can really get a sense of this if you listen in, even just to the first few minutes of a presentation with a patient. And they also fail to rule out despite refuting evidence. So a patient can tell them something that you think, oh gosh, that's important. That makes me think it's less likely to be, say, a problem with their stomach. But low critical thinkers don't take that into consideration. They still think it is something to do with their stomach, for example. So this is really important, I think, because it helps you to identify whether or not your learner needs some help in their critical thinking skills. One of the best ways to do this is just in the first few minutes of an interaction with the patient. Even if you just listen to how they gather information within the first 3 to 5 minutes, you can tell whether a learner is a high critical thinker or a low critical thinker. Thanks very much for watching this video. I really encourage you to try one of these teaching tips or techniques the next time you have a learner in your clinic.